City. And Dr. May attended the Creighton Medical School and did his residency at KU and anesthesiology. So he was also diagnosed in 1995. So thank you for listening, and thank you, Dr. May, for taking the time out to present with us today, and I'll hand it over.
All right, thank you. I'm happy to be here, and I'm glad that we could all make it, and that this is hopefully the recording will be helpful for those that can't make it. So I'm going to talk about anesthesia and myasthenia gravis, and so I'm going to try to share my screen here, so hold on with me. So I know that there's a lot of questions and stress about anxiety about having surgery when you have myasthenia gravis, and do the anesthesiologists and the surgeons and everybody know kind of about myasthenia gravis and what I can have and how am I going to do? And so I gave this talk a few years ago, but I think it's useful. So I'm going to go through this, and I won't cover everything in here, but I'll leave time at the end for people to just ask questions. So we talk about some preoperative preparation, kind of what you can do before having surgery, the kinds of things that you'll need to know ahead of time, some things in the operating room, and then some concerns that we have about after surgery and potential complications. So, so preoperative preparation, most places you'll get a phone call from some pre-op screeners or some nurses, and they'll kind of go through your history and ask you about your medications and things. So the anesthesiologist will have information about you before you show up. And then when they look at your history, they'll want to go through what kind of symptoms you have and how well is your specific disease control. Because as we all know, every myasthenic's different, and everybody has different symptoms that are controlled in different ways or to different extents. And so I think it's important that you're prepared to talk about your disease and what kind of symptoms you have and what kind of things give you problems. So some of the things that they would ask you about is any sort of skeletal muscle weakness, if you have double vision or diplopia, if you have any drooping eyelids or ptosis. So they'll ask for ocular type symptoms. They also are aware that there can be bulbar symptoms or things that affect your swallowing. And so they'll ask about problems swallowing, and then any problems breathing. They'll want to know about that if you have any medications that you need, or if you've had to have any treatments specific for your breathing. And then they'll just want to know other things in your history, just general history. So things that make it potentially more challenging to have surgery, or just that have the anesthesiologist have a little higher level of awareness and take extra care, is if you've had myasthenia for greater than 6 years. And these are all things that may increase your chance of needing some help with your breathing after surgery. So duration of disease greater than 6 years. If you take pyridostigmine or mestinon, a daily dose higher than 750 milligrams. If you have any chronic lung disease on top of your myasthenia gravis, that would make any weakness of your breathing muscles even more important or more risky. And then a preoperative vital capacity of less than 2.9 liters. So many people with myasthenia, if they've had problems breathing or even just with getting diagnosed for the first time, may be referred to get pulmonary function tests or go to a pulmonary function lab and have some breathing tests done, and that generates a report. And so the anesthesiologist can look at that and see what your vital capacity is. And if it's below a certain level, then that tells them that, hey, this person has a hard time taking a big breath. They may have a hard time really having a strong cough. And so if they have any secretions in their mouth or in their airway as they're waking up or trying to breathe, that they may not be able to cough as well as somebody, and we just need to take extra care in suctioning out their mouth and supporting their breathing. So just to be more aggressive at having help ready for those patients and just being prepared to quickly intervene to try to prevent complications. So let's go to the next one. So frequent questions are about, well, okay, I take all these medicines. Should I take them the morning of surgery? And the answer is, from an anesthesia perspective and surgery perspective, we would like you to take all the normal myasthenia related medicines that you take, because we want you as strong as possible and as optimized as possible. And so if you take medicines that do a good job of controlling your myasthenia, then we definitely want those medicines taken the morning of surgery, assuming that you can tolerate taking them on an empty stomach. You know, some people have sensitive stomachs and they have to take medicine with food. So then you have to kind of judge, well, can I take it or not? But certainly if you can tolerate taking medicine on an empty stomach, we would prefer that you do so. Any of your myasthenia medications, and bring those along too, because although the hospital has access to all the medications, it's always helpful if many surgery centers and hospitals will allow patients to bring in their own medication. So if there's questions about your dosages, then you can show them your pill bottles if you need to. Many patients I run into, they say, well, I don't know what medicine I took, but it was a little yellow one with numbers on it, and it was this big. And most people, unless you're a pharmacist, don't know what the pills look like. So sometimes we can look them up, and that's helpful. But it really is helpful if there's a question, just bring your medicine bottles along. Other things to think about is if you take blood pressure medicines, most blood pressure medicines are okay to take the morning of surgery, as long as it's not a diuretic or a water pill. The other medicine that we don't want people to take is like an ACE inhibitor, but you can ask your doctor about the blood pressure medicines you're on. If you take any medicines for heartburn or acid reflux, we always want those taken the morning of surgery, because that prevents you from having acid reflux and heartburn problems at the time of going to sleep and waking up, and when they're doing things in your airway. So that makes anesthesia safer from that perspective. Then any medicines you take to help with your breathing, we definitely want you to take. And I usually encourage patients to bring their inhalers with them, especially if they use a rescue inhaler. Like albuterol is often used as a rescue inhaler, just as needed. And if you think you might need it, it doesn't hurt to just bring it along. And the doctor may have you take some of your inhalers the morning of surgery if you feel like you're having problems breathing, or that it would be beneficial. So normally surgeons have, or anesthesia, one of the two, has a pretty good system of screening patients ahead of time. And I think that as a specialty, anesthesia does a better job of communicating with patients beforehand now than in the past, and hopefully we'll continue to improve that. So hopefully you're going to get some good instructions about what medicines to take or what not. But if you don't get instructions, please do not hesitate to contact your surgeon or contact your neurologist and before you go in for surgery that morning, and make sure someone gives you information that you need. You know, if you have questions, please do not hesitate to ask, because sometimes someone maybe assumes that a different office called you and told you that information, and so they don't give you the same information. And so please do not hesitate to advocate for yourself and for your family members. And if you don't get the answers that you need about how to prepare yourself for surgery, please reach out and ask your neurologist, and then they can work with your surgeon or ask the surgeon. So, all right, let's move on. So like I said, they're gonna go over your medical history and do a focus physical, usually listening to your heart and your lungs, looking in your mouth. They'll ask about your symptoms. You know, how's your medication going? Have you had plasmapheresis? Have you needed to be hospitalized for myasthenia? Have you needed to be in an ICU or on a ventilator? Anything like that. They might ask about your exercise tolerance. You know, what kind of activity you can do will help us to kind of figure out how you'll do after surgery. If you can tolerate more exercise, then you probably will have less problems with breathing and surgery than if you can't. But if you can't, that's okay too. We just factor that in and try to just take extra care for those people that can't tolerate a lot of activity because of severe weakness or because of other medical conditions. That doesn't mean you can't get through surgery safely. The anesthesiologist just is aware of that and has a plan in place to try to manage those symptoms to try to decrease the risk of any problems. They may, depending on the type of surgery, they will discuss the type of anesthetic, and depending on the type of surgery, you may have different types of anesthetic, and that could include general anesthesia, which means you're going to sleep for surgery, all the way to sleep, and in which case we usually have to put some sort of airway device in your mouth and potentially put you on a ventilator to help you breathe. Not all general anesthetics need you to be on a ventilator, just depending on if it's a less invasive surgery. Sometimes we can have people be completely asleep for surgery, but still breathe on their own without having to be on a ventilator. But other types of surgery require a ventilator because if they're doing something like a thymectomy, you need to be on a ventilator for that because you just can't breathe on your own when they're doing that surgery. So those types of surgeries require a ventilator, and there would be a discussion to the risks of that and what the plan is to manage your breathing and make sure that we give you the best chance possible to, at the end of the surgery, come off the ventilator without any complications and get back to breathing on your own adequately. So some surgeries can be done just under what's called regional anesthesia or local anesthesia. This would be like some skin surgeries, or if you have some orthopedic surgeries, only need regional anesthesia. If you're having surgery on your ankle, or like a knee replacement or a hip replacement, often is done under spinal rather than under general anesthesia. And so what that involves is doing an injection in your back, making you numb with some numbing medicine that they put near the nerves in your spine. And that makes you numb from about your chest down for the duration of surgery. So in that case, typically patients don't have to go on a ventilator. They just breathe on their own with some sedation. And so there's no risk of any instrumentation of your airway and the complications with that. So for total joint surgery for knees and hips, that's a common way to do anesthesia. Usually that's accompanied with sedation to just make you more comfortable. But that's a good way to do it and to avoid general anesthesia and not have to worry about complications of weakness or things like that. So some procedures are done under just sedation, and that would be something like a colonoscopy is done under sedation, where they give you medicine to make you sleepy enough to tolerate the procedure, but you still keep breathing on your own. And normally the risks with myasthenia may be less with that. But they still need to watch your breathing adequately. And so if you're having some weakness of your respiratory muscles, that just takes closer attention. Also, some patients with myasthenia gravis, depending on the medications, may be more sensitive to some sedative medicines. And so we just take that into account. Usually those medicines are dosed more symptomatically based on the patient's age and history and what other medicines they're taking and what weight the patient is. And so it really is tailored to the patient specific factors. And so we do try to be careful with the sedation medicines in patients that are at higher risk. So like I said, if you're having a general anesthetic, they may talk about a breathing tube that they place for surgery. And then depending on the surgery, like for a thymectomy, and if they're doing chest surgery, they may talk about the risk of having that breathing tube in for a short period after surgery, and going to like an ICU setting and being on a ventilator for a short period until you get a little stronger. That would be discussed in detail. And if that happened, you would be kept sedated and comfortable if that happened. But normally, if your symptoms are controlled and you're not having active breathing problems and it's not emergency surgery, that isn't very likely that has to happen. Stress dose steroids, if you're taking prednisone chronically, the anesthesiologist most likely will give you additional steroids to help deal with the stress of surgery. When you take steroid pills, your body's very efficient and it says, well, if you're going to give me that medicine, I'm not going to waste energy making steroids myself. So when you need an extra steroid because of stress of surgery, your body just doesn't make it as well. And so we account for that by giving additional medicine in your IV, steroid medicine, before surgery, and they may even continue that for a day or two after surgery, depending on if you can go back to eating or drinking or not. So they do take that into account. If you're on steroids, you most likely would get additional steroids right around surgery. Like I said, patients with myasthenia gravis can have increased sensitivity to sedatives. And so we just are careful with dosing and start with small doses. And then there's certain medicines that you want to avoid because they've been shown to exacerbate or worsen symptoms of myasthenia gravis. So the Myasthenia Gravis Foundation website has list of medicines. The MG Kansas City website may have a list of medications to be careful of. I know there's a lot of really good resources related to myasthenia gravis and medications to avoid. And so I would encourage everyone to print out that list or have that bookmarked on their computer web browser. So if they ever have a question about if a medicine is safe for me to take, they can look it up quickly or keep a copy in your purse or something like that. I also think it's a good idea to keep a copy of your medications in your purse or saved or your wallet or saved on your smartphone. So if there's any questions or you just can't remember what dose you take or if you're taking a medicine, you have a reference. So there's nothing wrong with having a reference of your medicines, because if you're taking a few medications, it's easy to get them confused. So that just helps you not worry about that. You just say, okay, well, I have this list, and just keep it updated. And that takes the stress away from having to remember all of your medicines. So a lot of antibiotics can exacerbate myasthenia gravis. Now, fortunately, most of these antibiotics aren't ones that are used commonly with surgery. Probably the most common ones you'd see with surgery that are on this list would be the macrolides. Clindamycin is often used if you have an allergy to cephalosporin antibiotics. But the most common antibiotics are cephalosporin class of antibiotics, like Keflex or Rocephin or Ancef, if you've heard of any of those. If you haven't, it's not a big deal. But my point is that class of medicines is not on the list that exacerbates myasthenia gravis. So, it's a good idea to be aware of the medicines that may cause a problem so that you can avoid them if possible. There are usually almost always other alternatives that can be found that can have the same coverage in a different way. And so hopefully you can avoid any of the medications that would make your symptoms worse. So other medicines besides antibiotics are these medications. Magnesium sometimes can, even in a non-myasthenic person, can cause weakness if you have too much of it, but in myasthenia gravis, it can exacerbate it. These other medicines, some local anesthetics. So just, I encourage you again, just to go to those resource sites and look at that list and just familiarize yourself with some of the names. It's too big a list to memorize, but it's good to have as a reference. So if you are going to have go to sleep for surgery, what they would do is once they get everything prepared and everybody's talked to you and you've signed all your consent forms, they may or may not give you some relaxation medicine, and then they would take you back to the operating room, have you move over to the operating table, and then they would hook up their monitors so that they can monitor your vital signs like blood pressure cuff to monitor your blood pressure, a pulse ox sticker, it's short for pulse oximetry. It monitors your oxygen level in your blood, which is really important. They monitor your heart rate. They put on EKG stickers that monitor your heart rate and your heart rhythm so that we can see if there's any abnormalities there during surgery. Then they'll have you breathe some oxygen for a couple minutes to try to get your lungs all full of oxygen. So when they give you medicine to drift off to sleep, your oxygen level stays up in a nice safe range while they have time to put the breathing tube in or the airway device in if that's what's necessary. So they'll have you breathe oxygen first. If it's a case where you're having sedation or you're having regional anesthesia with some sedation, they may give you some supplemental oxygen, either through a cannula in your nose or through a mask on your face where they can give you extra oxygen. Those devices a lot of times will have a little sampling line so they can still monitor your breathing through that device so they can tell how frequently you're breathing and make sure that you're still breathing and that's done safely. Certain types of general anesthesia, if you're having a thymectomy, for example, like I said before, they do need to give you some medicines called muscle relaxants to relax your muscles and make it easier for them to manipulate the instruments to do surgery without your muscle tension and natural muscle tone fighting against the surgeon. So it makes surgery easier for the surgeon, makes ventilation easier for the anesthesiologist to give these medicines. And so you don't really need to know a lot of details about that other than to know that there's one type of muscle relaxant that myasthenia gravis patients are kind of resistant to, and then another type that they're sensitive to. And anesthesiologists are well aware of which type of medicine that they're resistant to, which is only one. And then most of the medicines we use, myasthenic patients are very sensitive to. And so you often do not need the same dose. And so we'll start out with a smaller dose and we'll use a little monitor to monitor your muscle strength and make sure that we're not giving you too much of that medicine. And then also making sure that at the end of the surgery, enough of it has worn off and we can give you medicine to reverse the weakness from that. So that way your muscle strength is as close to normal at the end of surgery as possible. So your muscle strength will be, if they use those medicines, they will monitor your muscle strength and make sure that they're keeping a close eye on that. So people are sensitive to that, but the anesthesiologists are aware of this. And so it's not something to worry excessively about if you're having a surgery that requires relaxation. It can still be done safely, just has to be monitored closely, just like everything else. So, and again, I'll take questions at the end. So I apologize if I'm covering too much or going too fast. This is being recorded, so you can go back for reference and go back through the rewind and look at the slides again. So, like I said, regional anesthesia, things to consider: the spinal or epidural for a total joint surgery, or if you're a young woman with myasthenia gravis that's pregnant, if you need a C-section or you want to have a labor epidural to help with pain control during labor, those things can be done safely and effectively in myasthenia. And then talked about the benefits of not needing a breathing tube or a ventilator. We don't need to give muscle relaxants. And then some sensitivity to local anesthetics. So we just need to be careful of our dosing. So most of the types of local anesthetics that are in spinals and epidurals are a different type of local anesthetic that is not an ester. They're called amides. So myasthenic patients are not as sensitive to those. They're more like a person without myasthenia gravis. So post-op concerns, so things that are monitored closely, like I said, is your strength at the end of the case, and your breathing adequacy is monitored very closely. They can monitor the volume of breathing that you're doing. Every breath, we can see the volume that you're taking if it's on a ventilator, and then how often you're breathing. We watch your sedation level due to narcotics. You will get some narcotics with a lot of surgeries to help with pain after surgery. You also will get non-narcotic medicines like Tylenol or gabapentin, or forms of ibuprofen like Celebrex, or IV form called ketorolac or Toradol. So there's really trying to be a move to not just rely on narcotics. And so there's a lot of non-narcotic pain medicines that are used in addition to nerve blocks and things like that to decrease post-op pain. So If you do have general anesthesia and you do have muscle relaxants at the end of the case as they're monitoring you, some of the things as you're waking up that you may remember, but most people are still too sleepy to remember, is they may ask you to lift your head to demonstrate that your head and neck strength, and your neck strength specifically, is adequate, because that's a good judge of, is your diaphragm strength adequate and normal on your chest wall. So sometimes we'll ask you to open your eyes or squeeze our hand just to demonstrate, are you awake enough to follow commands and what's your level of awareness. And so if you're waking up slowly or they're concerned about any of those things, you may remember having something in your mouth at the end. The vast majority of people do not remember having a breathing tube in at the end. Usually it's taken out and an oxygen mask is placed over your face loosely by the time you're really awake enough. So you're awake enough to be breathing on your own and follow simple commands, but your brain isn't really fully awake. And so although you follow commands, most people will tell me that they don't remember anything until they get to recovery, or they remember going to recovery, but they don't remember being in the operating room. So that's the normal, typical, most common experience. But if your breathing is a little weak and they're trying to support you a little bit, or you're waking up slowly because you're sensitive to sedation, sometimes that breathing tube stays in an extra couple minutes, and some people have just a foggy memory of having something in their mouth. Normally, if that happens, it's not an alarming memory. Usually it's just a foggy memory of, yeah, I wasn't really sure, I remember something, but it wasn't really alarming or scary. But if that happens, they'll be reassuring you that, hey, you're doing okay, just take some deep breaths, and they'll try to get that tube out as much as possible, as soon as possible. So let's see. So that's really all I have for my presentation, and I kind of wanted to open it up for questions. And so let me stop sharing my screen. And then I'm not sure, Allison and Tanya, if you want to share the questions that pop up. I'm not seeing any questions up here, or I don't have that enabled. I apologize if I'm supposed to
okay.
chat things. So let me click on the chat here.
Can you hear me? I don't see any either.
I opened up the chat, so.
Okay. Does anybody have any questions they would like to put in the chat and we can share?
Also, hi everyone, this is Meredith O'Connor, St. Louis Program Coordinator. I am signing in for Allison tonight as she has prior other work commitments. So
All right, I misspoke, I called you Allison.
Oh, you're totally fine, Dr. May, totally fine. Yeah, so if you have any questions, please feel free to utilize the chat box or Q&A. It looks like we have a Q&A here. One attendee says, do you recommend a course of IVIG prior to surgery? If so, how many days in advance?
I wouldn't make a specific recommendation. I would defer probably to the neurologist on that, because IVIG isn't something that anesthesiologists prescribe or monitor. And so that's really that's a good question. I don't think that there's evidence out there that would recommend doing a prophylactic IVIG if you're not someone that would need it anyway. I don't know that there would be a recommendation to do it just in case or for added benefit. I think if you've had one recently or you don't need that treatment, then I don't think that there would be a reason to do it just because you're having surgery. But again, your neurologist would be the best person to field that question. But that's a good question.
Yeah, really good question.
I think so.
Let's
see. You mentioned ventilation with a thymectomy. Would that be for the robot minimally invasive method too? Yes. So the minimally invasive method is very good for a lot of reasons, because being minimally invasive means it's not as big of an incision. The recovery is easier, but sorry, the light's bad here. But you still need to be on a ventilator, because in order for them to do the minimally invasive part with the robot, they need to still have instruments in your chest. And so we still need to control your breathing, and it would not be possible for you to breathe with even the minimally invasive instruments in your chest. It just wouldn't be possible. And so you do still need to be on a ventilator and to have muscle relaxation, but the hope would be that the incisions are much smaller, so the pain after surgery versus a traditional sternotomy, which is what I had for my thymectomy, the recovery is a lot better, and your breathing mechanics are a lot better because you don't have a sternotomy that makes big breaths more painful. And so you're able to do the incentive spirometer and all the breathing exercises immediately in recovery and after surgery a lot better because it's just less discomfort. So I think being able to take big breaths better sooner after surgery makes the risk of pulmonary and lung complications a lot less. So hopefully that answers your question. Let's see. I'm having an EGD and colonoscopy next month. Does this procedure typically use sedation or anesthesia? That would be a good question. That's a good question. That would be a case of sedation. So normally, most places now are using anesthesia providers to provide sedation for GI lab procedures. And if that's the case where you're going, they would use a medicine called propofol, which works very well. It's kind of the standard for GI lab sedation with anesthesia. And the nice thing about that is it works very quickly and it goes away very quickly. And so it's easy to titrate or adjust to the patient's needs. And so they can give small doses that work very quickly, and they can give more if needed in small doses. And so it's easier to keep someone breathing on their own and to really watch things closely with a medicine that you can adjust very closely. And so it's a very safe medication in the hands of anesthesia providers. Just do not let a cardiologist give it to you in your house to help you sleep, because that's what Michael Jackson did. And that's why everybody knows it as the Michael Jackson medicine. But it's a very safe drug in the right hands, and we use it every day in anesthesia. And so there's no reason to be concerned about that medicine. But yeah, for EGD and colonoscopies, sedation is the norm, which works very well for most people.
Great.
I have a question in my email. Let me see. It says, I have 2 upcoming procedures, a colonoscopy and a possible leg vein ablation. Other than the doctor being aware of my MG diagnosis, should I look out for anything else regarding the sedation?
Not really. I mean, I think if there's an anesthesia provider that's doing this sedation, just tell them your history, and it never hurts to remind them of, hey, they told me that I was really sensitive, as a myasthenic patient, I might be sensitive to sedation. I just wanted to remind you of that, so that they're careful. But nothing really specific. Occasionally, if you're having a radiology procedure, like a vein stripping or something, there isn't always an anesthesia provider there, and sometimes nurses do sedation, and so which they're perfectly qualified to do certain types of sedation very safely. But it's a good idea just to remind whoever you're working with that you're sensitive to these, and remind them of the medicines that you're on, and that you're on. If you take prednisone, remind them that you're taking a steroid. So in case, say, hey, they said you might want to give me extra steroid medicine because I take prednisone. Do I need it for this procedure? A lot of times for sedation, we don't always give stress dose steroids because many times the procedures are very short and they don't stress your system that much, but it's always good to keep in mind in case.
All very good questions, though. It's great.
Yes, good question.
Does anybody else have any other questions? Now's the time to ask. Again, feel free to use the chat box, email Tanya, whatever. But if not, I can probably wrap things up in a little bit.
If anybody comes up with any questions, they're more than welcome to email me. I can see about getting them answered.
Yeah, and I'm happy to if Meredith or Allison or Tanya or anybody, if you get questions from patients, if you want to, you have my email address. So if you want to send me an email, then I can try to get you a reply quickly on that. I'm happy to answer questions, or if you have a whole batch of them, I can
Just
answer
put them all
questions.
together. Thank
So
you.
I'm happy to be a resource. I'm sure that there may be other people too, but I'm happy to take those emails if needed. So
Thank you so much. This has been incredibly helpful, and I know a lot of people have been requesting this and are very interested in learning about this topic, as I think it, anesthesia is scary for some people. So I think being educated about this with especially someone who has MG is even better. So thank you so much, Dr. May.
yeah, well, no, my pleasure. Thank you for asking me to do this, and I hope this was helpful, and I hope that people feel a little bit more at ease. Yet having surgery and anesthesia is scary for a lot of people, but you're going to be well taken care of, and people are aware of this disease. Your medical professionals are aware of this disease and how to try to minimize the risks to it. And so I think you can have surgery safely without complications, but happy to answer other questions. Hopefully this will be a good resource for people. So thanks for the invitation. I appreciate it.
Great. Thank you so much. Have a good evening.
All right, you too. Thank you.
Thanks.
Good night.
everybody.
Bye. Bye, everybody.